Hi class, this is Dr. Heather Austin Robillard, and this lecture video is going to be over the theoretical models of addiction. Throughout decades, theorists have developed many models in order to better understand and explain addiction. In order to thoroughly understand addiction and recovery, it's important to know about the theoretical frameworks that exist. In this module, we will cover the medical model, the disease model, which is informed by the biopsychosocial approach. We'll also learn about the self-medication model, the harm reduction model, and the process model of addiction. We'll briefly talk about the sexual addiction cycle developed by Dr. Carn as well. Before we go into the models of addiction, I want to talk a little bit about the scientific model. The scientific model is where scientists represent a particular phenomenon in the world using something else to represent it, making it easier to understand. A scientific model could be a diagram, picture, a physical model, a computer program, or a set of complex mathematical equations that describe a situation. So in this page, we're going to talk about how people present their information in a scientific model. So as you can see with the people, we have patients, a treatment group, and a control group. So a treatment group is the group of individuals who we give the treatment to. So maybe it's a medication, maybe it's a specific type of therapy, a surgery, whatever. And then the control group is a group that is very similar to the individuals in the treatment group, but we do not give them the treatment. We do not give them the therapy service or the medication or the surgery or whatever. And then each of those groups have a follow-up, and we compare those results. This tells us whether this treatment was successful enough if there's a significant difference between those individuals who received the treatment and those individuals who did not receive the treatment. So basically, the hypothesis was, does X cause Y? Does the treatment cause substance use disorder? Now, this comes with difficulties in the social sciences because we can't necessarily give addiction to a certain group and not give it to another group, right? This comes with ethics. So typically what we're measuring is not an actual randomized control group. This is the gold standard in establishing causality. So typically what we're trying to find is a representative sample of everything that is in the control group that we compare. So maybe instead of giving addiction to one group or not, maybe we're going to try to find individuals that are similar to those who have addiction in that group and those who do not have addiction in another group, and compare those groups as needed to find significant results. Why this is important to understand is also because when we look at the results between the treatment group and the control group, we need to recognize that correlation does not equal causation. So correlation is the relationship between two sets of data. So you can see here the graph of what are the different types of correlation. A strong positive correlation would mean that when one relationship increases, the other relationship increases. And it has a strong strength of that. So almost always the individual with a high test score will also have a high IQ score, right? Whereas a weak positive correlation might be that typically it's going up, but not everybody has that high test score with a high IQ score. A negative correlation is where one relationship factor increases while the other decreases. So let's say drug use increases, attendance decreases, and this happens for most of the individuals, so it's got a strong correlation. A weak negative correlation would be that we are kind of seeing this trend towards drug use being related to attendance. However, not everybody fits strongly into that relationship. And then you can see the moderate negative correlation or no correlation at all. That means there is no real relationship between substance use and attendance rates. Now, a problem that often comes along with correlation is that there might be several different factors that are causing this strong relationship that aren't actually related to the problem. We noticed that in 1991 there was 281 babies named Ava, and the housing price index was 100. And then as the names Ava increased, so did the housing index. However, these two are actually not related. There were probably other factors that increased babies named Ava and the housing index that were separate, but they just happened at the same time. So you can compare two things and they can have a high correlation, but they may not be related at all. And that's what's important to look at when we see data. Another example here is autism versus organic food sales. What could also be relating to that? So we need to look for the other alternative factors that might be causing this correlation strength. This we see a strong negative correlation with divorce rate and per capita of margarine, right? Those aren't related, but they have a strong relationship here. So the saying is, correlation does not equal causation. So just because they have a strong relationship does not mean that X equals or causes Y. And in the scientific model, what's important to know about this is the scientific model shows that they have a hypothesis, they have a question about two factors relating. They develop a theory based on these hypotheses and the results they get from these hypotheses. And in this theory, they develop a model of what does this phenomenon look like. And so that's what we're going to be talking about when it comes to addiction, is that all of these models have been based on hypotheses that have turned into theories, and then these models depict what happens during this phenomenon. So first, let's talk about the medical model. This model assumes that the primary cause of addiction is a biological or genetic component. So people pass down this gene and that's why they become addicted. Treatment from this lens will focus primarily on physical symptoms of addiction. They aim to alleviate the addiction symptoms. It has led to the inclusion of using medications to cure craving, that drug memory. Using this model, we have gained a better understanding about how addiction works and how to recognize it. The next model of addiction is disease. As you learned in the history of addiction, Benjamin Rush in 1784 was the first person to label addiction as an odious disease. The American Medical Association then later named it an official disease in 1956. They named it a disease because it met the following criteria. They realized that it was progressive, it manifests identifiable symptoms, and it occurs chronically and can be fatal if left untreated. So the disease of addiction fits all of these criteria, which is why the American Medical Association called it a disease. This model is what informs most of our treatment procedures today. The two basic understandings of this concept are that addiction is a disease with biological, psychological, and social components to it, and that the treatment for addiction requires abstinence. According to this model, relapse is viewed as anything that is non-abstinence. This is different from the medical model of addiction because we're also including the biological, psychological, and social components and not just alleviating the symptoms. The biopsychosocial approach explains why people start using, how they become addicted, and why they keep using. It is the most common approach, and it is just like it sounds. It combines biological components, hereditary components, with family history, genetic predispositions, physical health or mental health problems. It combines factors of neighborhood, community, peer group, socioeconomic status, low self-esteem, among other things. It helps us know that it is not solely on the fault of the addict, but there's other components that lend to this disease developing and being maintained. The self-medication model found that people will use substances or behaviors to self-medicate or to reduce their own physical and emotional pain. Examples of this are using depressants like alcohol or heroin to numb the pain, or stimulants may be used to increase activity or combat depression. Treatment involves identifying the emotional distress that an individual is experiencing and having the individual work through that emotional distress. The harm reduction approach is more of an approach to treatment that does not believe in complete abstinence in order to be healthy. The client or the addict will develop treatment goals that are reasonable to them and will work to meet those goals. This model is based on 5 principles. Reduce substance use when abstinence is not feasible or it seems like it is completely unmanageable. Addiction rests on a continuum. It is not dichotomous like addicted or sober. The continuum starts with abstinence, then goes to experimentation, abuse, dependence, and addiction. It focuses on the client's specific needs and intentions. There's also a low stigma to this approach. The model tailors treatment to meet the client's need without judgment. It's a very compassionate and pragmatic approach, meaning that people are encouraged to be compassionate and realistic instead of forcing their ideals or moral standards on the individual. They acknowledge that the risky behaviors may happen and will happen again and are accepting with less shame. They do not see use as failure per se. Examples of harm reduction approaches include needle exchanges, where people are trying to reduce the likelihood of transferable diseases through needles, so providing those needles to drug users so that they're reducing the harm of physical ailments. Methadone, which is typically used for people to reduce the symptoms from coming off of heroin. Controlled drinking, if one can manage their intentions and not abuse it. So they're trying to minimize the amount of drinking they're using or minimizing the harm, like DWIs and everything. And then nicotine patches is used to reduce nicotine cravings for those trying to quit smoking or chewing tobacco. The process model of addiction and recovery explains human behavior in response to pain and illustrates a cycle of addiction. This model implies that every human being experiences pain at some point, either physical or emotional. In response to this pain, they participate in a behavior, usually to cope, and these behaviors may be unhealthy or healthy. After this, they will have a response to their behavior. This is some kind of result based on the behavior they took. The results can be good if the individual used a healthy means of coping, or it can be less favorable, resulting in feelings of shame, guilt, and desperation. This model can be applied to compulsive behaviors and addiction. This model can be applied to compulsive behaviors and addictions. The feelings of guilt and shame as an end result are painful, which brings us back to the beginning cycle of pain. The model can also be applied to healthy coping. The positive results that come from healthy coping behaviors are typically heightened, a sense of self-esteem, which can lead to positive consequences and promote resiliency. So the next time a painful life event occurs, an individual may be resilient enough to not want to engage in the behavior or substance to alleviate their pain. The last topic to cover in this module is the Carn cycle of sexual addiction. We highlight this model because it fits well to describe the obsessive compulsive nature of addiction, especially when it comes to behavioral addictions. We will cover more about sexual addiction in the process modules. However, with Carn's cycle of sexual addiction, the addiction cycle starts with a belief system paired with impaired thinking to the point of unmanageability. This 4-step addiction cycle starts with preoccupation, when the addict will begin to ruminate about the behavior. These thoughts will occupy their mind completely. The next phase is ritualization, which is when the addict will start to engage in the behaviors. They may increase excitement prior to the actual behavior. For example, maybe they're driving to a porn star on the way home from work, and that continues to escalate. Next is the sexual compulsivity stage. This is when the person actually engages in their desired behavior: masturbation, porn, prostitution, sex. The last stage is despair. Similar to the guilt and shame stage of the process addiction model, this is when the individual will feel self-loathing and depression, which will cause them to become preoccupied again with their sexual behaviors, starting the cycle all over again. There are 3 levels to sexual addiction. Level 1 includes behaviors that are typically viewed as normal. For example, this might be masturbation, viewing pornography, or having multiple sex partners. It also includes things like paying for prostitution. Level 2 of sexual addiction are those behaviors that are victimizing and that have legal sanctions against them. These behaviors include exhibitionism, voyeurism, indecent calls. And level 3 sexual behaviors are the severe boundary violations and are also illegal. They are laws established to protect the vulnerable. These behaviors include rape, violence, sexual behaviors, child molestation, or incest. That is the end of this lecture video.